Support for this podcast comes from Bryn Mawr Communications. BMC produces a number of informative podcast series spanning a variety of topics in ophthalmology. Discover a new show at itube.net/podcasts.
Hey everybody, welcome to another edition of Collaborative Corner, the podcast. We're coming to you from whatever medium you're going to be using, whether it be an iPhone, an iPad. I don't know. Can you listen to stuff like this on Androids? I'm not sure, but hey, if you can, you be you, boo. I have no idea. But more importantly, I am excited today to have a conversation about a topic that, the fact that this is a podcast kind of implies that you can't tell what I look like. And more importantly, you can't tell that I'm aging and all the other things that go along with aesthetics, the aesthetic nature of ourselves. I literally had somebody say to me the other day, "You look so different." And I said, "Really?" They're like, "Yeah, you've gotten older." And that was really, really, really sweet. That was one of my kids. So I am fortunate enough to have today Dr. Gina Wesley from Complete Eye Care of, is it Medina or Medina?
Medina.
Medina. So I mean, if I was in your practice, Gina, I would be funky cold Medina.
I have a hat that says "Funky Cold Medina."
I love it. I love it.
It's great.
Gina is coming to us not with just her OD, her MS, her FAAO. She's, clinical trials. She does. I mean, I don't want to tout all the things you do, but I'm more impressed by the fact that you have a private practice. So you not only run a practice, but then you do all the other extra things that most optometric clinicians will say they don't have time to do. And so I am floored by the fact that it's like you can kind of do all these things and you're a mom of two and you have a husband who's needy, all of those things.
Well, thank you. That's really nice of you. I wouldn't be able to do it without an incredible team of people. And you have to remember, I don't see patients, 5 days a week. So it does help a bit to be able to spread out some of that time, but those things have grown organically as I've had my practice. They've, all come about. I used to not do as many things, and it's been added to over the years.
So okay, so let's start by that. So let's say you're an optometrist who's A, either just starting out, or B, you want to branch out into doing other things. And I get a lot of ODs that say, "Hey, how did you start doing clinical trials?" That's something for another time. I think, "Hey, when did you start writing and lecturing?" And again, that's for another time. But what are the tangible things that you do in your practice to actually help your patients, but it also enhances your practice and sets you aside? Like, did you decide, okay, every year we're going to add another piece of equipment, whether it be diagnostic or therapeutic, or you said that it became organic? Was it patients would come in and you noticed that it's like there's some technology you could have to help the patients that you've been seeing?
I think it was more the latter where I was like, I'm really missing this piece of information, and I think that would benefit my patients, but then it made it so that it was almost like a new piece of equipment every year. And I like to have, great technology and experiences for my patients. We have a very preventative approach to practicing and seeing patients. And so I like to be able to have the technology that educates them, and that parlays into lots of other areas where all of a sudden you become a little bit more of a specialist and you know a little bit more about a specific area of your practice and you can branch out from there.
So did you start by like with contact lenses? Did you start with dry eye? Did you start with I mean, did I say contacts? I said that twice now, huh? I think I said that because I have PTSD because I had two contact lens evals today. Because we have somebody in our practice who went on maternity leave and she likes to do contacts. And I walk in and my first thought is contacts. You don't really want contacts, right? Is it really? Come on, really? So yeah, I have PTSD. But was there one kind of area that you were working on originally?
So I think it probably I started my practice cold about 18 years ago. And I just naturally fit a lot of contact lenses, which I know you said we're not going to talk about clinical research, but that led into some speaking in clinical research that then enhanced my expertise. And I found that I was one of the top prescribers of multifocals in my state, even though at that time I was only seeing patients about 2.5 days a week. The practice was very young. So I was like, I guess I'm doing something a little differently. And so that natural expansion into just being a high percentage fitter and success with my patients in contact lenses then led us into like orthokeratology. And then if you have contact lens wearers, that naturally segues into dry eye. And so those would be the two big areas that my practice specializes in based on previous experience and how that kind of organically built based on what patients needed.
Yeah. Okay, so I know we have to diverge. We have to kind of, pivot. Is there do you is there one, two things, two kind of just like tips you could give people on helping patients with multifocal contacts? Because the
Yeah,
percentage of OTs that prescribe them is paltry. It's like so low.
it is. And so I tell, doctors, I say, this is what I say to patients. I say, here's the reality and the expectation with multifocals is to keep you free from needing to grab reading glasses or another means of correction to see clearly up close about 50 to 70% of the time. Pause. The patient will weed themselves out right then and there if they're not a good candidate. But if they're like, okay, and I say, look, it's going to be difficult in dimly lit restaurants. You will see some glare and halos when you're driving at nighttime, but you're going to gain a lot of flexibility in your vision. So you should see this as a tool. Everybody's day to day is a little bit different. So we won't really know until we fit you, but that is the realistic expectation. And when you level set it, I think, like I said, that helps weed out the people who would already have failed. And then that helps you with the patients who are remaining because they get it. And then they're like, oh, they don't have too high of expectations. And that helps a lot.
Yeah. You actually nailed something 18 years ago when you first started doing this, which is everything that we do in our practices is about expectation setting. And I feel that for those of our colleagues that struggle with dry eye or contacts or refractive surgery or even glaucoma, um, you know, it always boils down to what is the end game? How can we determine that we've actually accomplished what we're trying to accomplish when the reality is I almost kind of feel like we never do. And so it's getting patients to understand that this is, you know, like you said, level setting the expectations. This is where we're going to be, and for patients that have too high of expectations, then they need something different, but more importantly, especially with dry eye, it really comes down to letting patients understand that this is a dynamic disease state that we will never cure. And so what we can do is do the things that we can to, manage it. And I think you've done a phenomenal job with that. And it's interesting to me how it's like you just mentioned, talking about, ortho K. And I think you've done stuff with refractive surgery as well, right? Where patients who are like, I don't want to wear the multifocals. I want to get out of that, and setting those expectations.
Yeah. And I think the important thing is you have to keep setting and reminding of the expectations. It's not just a one-time conversation. And I think that dialogue and figuring out what patients' goals are, because everybody's goals are different, especially with dry eye. You know, some people, all they care about is the appearance. Some people, all they want is some symptomatic relief. Some people just want to wear their contact lenses longer. So you really have, if you can figure that out, that helps quite a bit in your success rate because you might be really working hard to maintain their meibomian glands and get them open, flowing, and moving when all they really wanted was just to look a little younger and for me to tell them everything looks good,
Yeah.
right? So if you could figure that out, that will increase your chances of success.
I think it also goes to the point where, oftentimes I've seen patients that come in and say, well, the doctor prescribed this for me because they told me I had dry eye. And I'm like, well, they did tell you what this was going to do for you. Did they tell you what you could expect from it? It's like, no. And so it's like you have to go into any of these things with saying, this is why we're doing this. this is what you can hope to expect or not expect. I mean, sometimes not having a symptom to me means that we're doing well. Something's humming in the background. But I'm gonna change topics a little bit.
Okay.
I went to Chat GPT because why? Because that's how I roll. And I said, "Hey, Chat GPT, what's ocular aesthetics?" And he told me that it's this. Well, it's a he because that's I'm
Is
I'm
it?
I'm sexist. I'm sexist. Okay, mine has an English accent. He's from England, smushing, and it's like sometimes it's a little pithy with me, and I actually like that. I think I deserve that. So yeah, is yours a female? Does yours go?
Female Australian.
Oh, oi, mate. Gay girl. Go get it.
She
Yeah.
is very posh.
I can't do that. I wish I could do an Australian accent. So it's basically this is a specialized field of care, of eye care that focuses on the appearance and health of the eyes and the surrounding facial tissue. So this bridges the gap between medical eye care and cosmetic enhancement, addressing issues that affect how eyes both look and function. And you literally just said that. And you said it without really defining ocular aesthetics. You said some patients care about how they look, some patients care about how it functions or how their symptoms are. So talk to me about how you've incorporated, the devices and the tools you have into your practice to kind of to manage both of those.
So, just like we had talked about kind of that organic approach, it started out as me getting a treatment for gland therapy, right? Thermal heat pulsation to help get the glands. And all of a sudden those patients are like, "Gosh, I feel better." I'm seeing that clinically they look better and um, they feel like they look better, right?
Right.
And everybody likes to look better, right? That was a nice added benefit. And so as we started to add more therapies like IPL and radio frequency, and now we do radio frequency microneedling and dynamic muscle stimulation, all of those things not only help dry eye, but patients are thrilled with how much better they look. And really, the two are not mutually exclusive. Even if you practice somewhere where maybe you can't do as much aesthetics, you will help patients look better if you help their dry eyes. So, ocular aesthetics, really, my argument can be done, through a variety of means of different treatments and therapies for your patients, whether that's the intended outcome or not. And intentionally for my practice, it is now. We had some scope expansion last year that allows us to be able to do a bit more with that. And patients are thrilled to be able to expand beyond, "I've been doing all these treatments for dry eye and I've really loved the improvements in my appearance, but now I can even do more of that to help with everything at working in tandem." And so, as I like to tell patients, it's really nice to be able to help attack the dry eye issues from a variety of mechanisms of action. And every patient responds differently, and some respond predictably, and some, more so to one therapy than the other. And then it's our job to figure out which is working best and to continue along that vein.
Is it mainly females, or do you also see a lot of your male patients who are kind of fall into the same
So,
category?
it is mostly female at this time, but we
Uh-huh.
do have some guys that really do appreciate the therapies and improvement in appearance, especially if they suffer from rosacea.
Mhm.
They've got like prominent veins on their face, nose, chin. Those are the guys that really appreciate what we can do for them, especially through IPL. So yeah, we still do have guys, but definitely a little more female heavy.
Yeah. So a couple of things. Okay, I mean, I could just keep going on because questions keep coming up. So first and foremost, you mentioned DMS. Okay, is that digital? What is it?
Dynamic muscle stimulation.
See, I knew I was like I thought it was DMX because we're like funky cold Medina. Then we got some DMX. I'm gonna make it up in here. I would say DMS. Yeah, what? So that is to me, that seems relatively new, is it?
It is relatively new,
So
and so
can you talk about that for a couple
yeah,
seconds?
so dynamic muscle stimulation helps with, like, facial toning is the best way I say to my patients. I say, we all know we're fighting gravity. Mark, maybe you not as much as
Oh,
others, but
gravity. Yes, no, totally. John Mayer and I are both fighting gravity.
But right naturally, and patients can relate to this. I was like, gravity. I use my hands a lot when I speak, and I know this is a podcast, but gravity is pulling everything down constantly. And so we talk about how that impacts our lower eyelid structure particularly, and they can see this with bags. They can see this with under the eyes. And then I say, and it affects your blink, right? And we know that this is important because as our patients age, if your patient complains about, I wake up in the morning and my eyes feel really dry, we know there's some component of lag ophthalmos. And that's likely because, in part, their lid structure is not as taut as it once was. So, the combination of dynamic muscle stimulation and radio frequency helps to retone, tighten, and get those muscles active so that you are going to get an enhancement in structure and function because of the better dynamics that are engaged and initiated.
Right.
If you combine that with some radio frequency microneedling, you're getting the best of all worlds because you have these various methods of tightening. Now, we always tell our patients this isn't like getting a facelift, right? A facelift is a permanent change, right, in that structure. This is something that has to be maintained. The studies that show that the benefits last for about 12 months, then you have to do some sort of maintenance, right, to be able to improve that. But for patients who want to avoid surgery, have less invasive means of helping structure out, we found it to be a very effective way in which to do that and help their dry eye.
So, how many treatments do they have to have? Is
So the
it
protocol we have is there's 5 treatments about
okay?
every 2 weeks. Every treatment has the dynamic muscle stimulation with radio frequency. But on the 1st, 3rd, and 5th, you're also pairing that with radiofrequency microneedling.
Gotcha.
So you're not doing that at
Interesting.
every treatment, that would be a little bit much for the
Right.
skin to take, but the combination of all of those has been it's shown, and what I see with patients as I've been following up with them because we just incorporated this into our practice less than 6 months ago,
Mhm.
but as I see them for follow-up, remember, we're not even doing like a gland evacuation treatment. We're treating around the eyes where we're not even directly on the eyelids, but the improvements in gland function and the reduction in inflammation and what I'm seeing clinically and what I'm seeing on their speed score. The speed survey is how we gauge our patient's symptoms. Tremendous improvement.
Yeah.
Tremendous improvement. I mean, really, really beneficial.
Just so I mean, I have patients constantly asking me about the bags. Did I say that right? The
You start,
bags under the under their
oh, you're gonna
eyes.
make fun of me. It's fine.
No, it's fine. I was at the bubbler and I was talking about the bags. Yeah, so the if I mean, so that would be a good treatment then. I mean, because
Yes.
I'll be honest with you. When patients say to me, "What about these bags?" I'm like, "Well, like you say, I tell patients it's gravity. You know what? Everything's kind of dropping, so it's filling up with fluid. And they're like, so what can I do about it? And I go, all right, I'll see you in a week or two. I mean, so that actually would help to tighten that up.
Yes, and that is the probably the number 1 reported, like, "I love this treatment, fill in the blank." It's because of the reduction of that under eye tissue.
Wow, that's awesome.
And what's interesting is if you think about the surgical side of things,
Mhm.
when you do a lower lid bleph, you have to be very concerned about potential loss of orbital fat.
Right.
The one area in our body we do not want to lose. We want fat, we want it to be filled in. But if you take too much away, then the tissue is going to be more right, like saggy.
Shoelaces, like, dropping, yeah.
Exactly. So
Mhm.
the RF microneedling for that under eye area and around the eye has been amazing for patients in the reduction of that appearance.
So what those do is very similar to kinda to the cornea, where you basically like, with radio frequency, they do, like, you needle it to basically and then it would radio frequency would cause it to tighten around
Mhm.
that needling, almost so it keeps it taut. So it's kinda similar scenario. I love that.
Well, and I was gonna say too, for patients who are familiar with microneedling in more of a cosmetic setting, like a med derm spa, there's a lot of different types of microneedling, but this particular one does not require a numbing of the skin because it's not penetrating so deeply that it's gonna be that you have to
Right.
numb it up to be able to withstand it. I tell patients sometimes get a little nervous and they're like, "What is it gonna hurt?" And I'm like, "No, it's like taking a piece of Velcro and pressing it into the skin."
Right.
repeatedly. It's like a little rough, right? But it's not so painful that you are coming out of it like that was a really, really uncomfortable procedure.
And is this something that you feel a technician can do and then you come in afterwards, or is this something that you do?
No,
Is
so we do have a trained and licensed esthetician who
okay,
is delivering this treatment. Yep.
nice.
Now
I
I
love
was
that.
trained on it. Can I do it? Yes, I
But
can. I can, but it's not the
best
greatest use
use of
of
your
my
time.
time,
Yeah.
which is another podcast all in of itself.
I don't yeah, 100%. But okay, so you had told me though that IPL is something you do the most.
I do.
Yeah, so I know a little bit about IPL from the perspective that it doesn't really work on tone or texture or kind of the volume of the aesthetics,
Mhm.
but it does work on the inflammatory aspect and kind of like taking away the
So, yeah, so an IPL is the most of what we do for treatments, and that's likely because we've had it for about 9 years in my practice, and we have a lot of experience, which has helped guide us, with it, but I always tell patients, I go, "Look, IPL is gonna target the inflammatory vessels that are feeding into and around your eyes, and they're causing the clogging of your glands, the symptoms that you're having, right, in the first place." So we can get glands open, flowing, and moving, but if we don't solve the underlying cause of why that's happening, that's why it's just gonna continue to happen again and again.
Right.
So, when we do I say, you've got the intense light, it's targeting the pigment in those that are called pigmented chromatophores in the blood vessels, making them go away. We're very cautious, obviously, depends on your skin type. This is something where you do have to pay attention to patients and the pigment in their skin. I live in Minnesota, as you have pointed out with your, some of your jokes and comments. You are
What?
in a place where you always have to be worried about pigment in the
Yeah.
skin. I do not. I have about a good 9 months of the year that people are pretty good candidates for IPL with
Your
the
your
skin
your average Fitzpatrick scale is what? A 2?
I would say it's a 2. It's a
Pink.
2,
Pink.
pink. If you're lucky, you get a 1. I always tell patients, I was like, "This is great. You're a great candidate for this." But rosacea really is, just such a common here, and that's what IPL responds to, and I always tell patients, I go, "Remember, rosacea is affecting your sebaceous or your oil glands, and meibomian glands are specialized sebaceous glands," so that explanation helps to
I love
them to
that.
understand, but yeah.
Yeah. So, okay, so we're rounding the corner here because we've talked about so much, and I could keep going on and on. Like I said, I mean, I learned more listening to this than the 2 people that probably stayed on this long. Um, and, one of them is probably one of my kids, and, what I was gonna say, though, is that low level light therapy, LLT,
Yes,
right? Do you have that in your practice?
I do have that in my
Oh my
practice.
god, you have everything.
I do, I
Okay,
like
what so do you have, like, the whole spectrum? I think there's, like, what, 24 different, colors and
yeah. So we have blue, red,
okay,
yellow, infrared.
infrared, okay, so those are the 4 main ones.
Yep, yep.
So I okay, so just, kind of just kind of, go off a little bit on LLT, and I'm gonna end it, but I want you to tell me why how is that different than somebody going into, like, the Mall of America and going in and looking for a red light therapy over at the Nordstrom's counter,
Mhm.
or going on the Amazon and getting, like, their own blue light therapy for home?
So I tell my patients, the device that we have is medical grade,
Yeah.
right? So you're getting more, it's a lot wider, right, than just like a mask or something that you're putting and rubbing on your face. So I think that there are devices out there, and I tell patients if that's something that you want to pursue and you feel that it helps you, I that is your choice. But I have been really happy with low level light therapy especially when we pair it with another treatment.
Right.
It seems to enhance the results because it helps with the inflammation post treatment. I tell
Got
patients, I go, remember the mechanism is that it's increasing the energy and rejuvenation of those cells. Right? So, it feels really good too, which patients like, and this is a nice treatment. I tell doctors too, if you have patients who are reluctant to move forward with something that seems a little bit more, spicy or irritating or they're worried about it. I was like, this is a nice treatment to have patients, undergo. It can help a lot with, reduction of inflammation when somebody has like a sty that they're, a hordeolum that they're trying to heal. But like I said, I just find that it seems to enhance the results. I do like to preferably pair it with other treatments to get those better results.
Yeah, because I think the yellow is, like, for wrinkles, the
Mhm.
infrared is, like, kind of the deep for the discomfort, the pain that you were just talking about, and I think the red is, inflammation? Is that the red is red? And then the
Correct.
blue is for
Antimicrobial.
antimicrobial, right. So when you say and it without you, I don't want you to break down your cost and price structure, but when
Mhm.
you combine these procedures, do you have you're coming in for this, so these are the procedures we're going to do, and this is how much it's going to cost? Or do you break it down and say, this is what's in your best interest, so we need to do these three things, and this is how much each one costs, and let patients decide if they want to do it?
Yeah, so depending on the patient, right? Depending on if you're new to my, sort of dry services, we feel out again, what is your concern? Clinically, what am I seeing?
Right.
We do utilize educational videos that we send them so that they are educated a bit more extensively than in the exam room. Not long, but it's nice to hear it again, right? And so I always write down, these are the treatments I would recommend and why, you know? And I will tell my staff, they know. I'm like, if they only pick one, like this is the one that they would need to start with. But we really do try to utilize packaging things together. So we do have per treatment pricing, but when we lay it out, right, we have very good information that you as a patient would see to be able to digest. Oh, if I do these treatments, this is how much this is. If I do these, HSA, FSA flexible. We do offer financing. And about once or twice a year, we do run some specials and promotions on specific treatments or to kind of, allow patients to potentially try things out that have never done it before so they
Yeah.
can see how that best benefits them. Yeah.
That's awesome. I mean, I know that when patients start seeing improvement, they're just like, I can't stop. I mean, there was a skincare group here that was doing YAG and IPL for like melasma and for acne scars and for rosacea. And the results were phenomenal. It's just like you just add it on and just why couldn't we do that in the optometric practice? And you're doing it. And it's just amazing. So I want to end by asking you two more questions. Okay. One, do you have information you give your patients, like guys, the guys that have guy liner or the, females that wear a lot of makeup and they say, oh, is there specific makeup you recommend? Because I feel a lot of the male optometrists just kind of go, huh? Um, do you provide information for patients about that?
I do, right? So when patients come in, we talk a bit about depending on you get to see what their makeup looks like oftentimes. And so we talk about appropriate application, right? Under the lash line for eyeliner, not on, no tight lining, right? Right on the lid margin.
Mhm.
We talk about proper makeup removal. I'm like, are you removing your makeup every night? And I can see if it's flaking off onto the lid margin. I know you can too, Mark, when you're
I
looking under the microscope.
Oh, I can. Oh, I
It's
can.
pretty telling.
Yep.
We talk about and I take pictures and I'm like, "This is what I'm seeing, this is why it's bad." So we talk about appropriate makeup removal. So I'll recommend just because Bausch& and Lomb has tested so many of their products, the eye illuminations line, which includes Lumify, but there has their micellar 3 in water, 3-in-1 cleanser. It's got some other products that have been safety tested, which most companies don't go through. So it's nice to know those are really nice. So we talk about hygiene and habits in addition to and that segues into, you know, lid bleph issues, things like that. For guys, it depends, but if I were to give advice to male optometrists, I would start with, you need to be comfortable talking about if you see something with their makeup that doesn't look right, and if it doesn't look right. If it's not in this place that it's supposed to be, you gotta say something, right? Because sometimes women don't know, and I'm like, "Look at this," and, they didn't know I didn't know that it wasn't supposed to tight line. That's bad. Why is that bad? Tell me why, right?
So
And
would it
so
be bad if I just went, "Girl, did you like go to clown college to learn how to put that on your eyes?" Would that be bad?
maybe
Oh,
let's
okay.
tweak that a little bit. We'll talk after the recording here.
Yeah. It's like, I'm like, okay, did Stevie Wonder put that makeup on your face? I mean, come on. You are tight lining so hard right now. Okay, you're not maxing.
You're already there, you're a natural.
I got it. You're not mogging. Okay, you're not gonna mog the way that it looks right now. So, all right, one last question. If you could have one, what's in the future, or what's something else that you feel you would love to add to your practice, or have they not come up with it yet, or you don't know?
I don't know. I think I have everything that I I want at this
You've
point. Who knows what the next thing will be,
That is
right?
true. That is true.
I would love to see treatments that are maybe quicker, a little bit easier, but just as effective. That would be really great. Things that you could do immediately following an exam without having to necessarily schedule patients back. If we can figure that out, that would be awesome.
Nice. Very nice. Love it. Okay, do you do photography though? Do you take pictures and show patients
Yes.
and stuff? Okay.
Yes, we do take before and after images.
It's amazing. Love it. Well, I learned more about ocular aesthetics in this 25 minutes that we've been talking than I did in 32 years of practicing, but I'm excited. I love this. The one thing that I love though is that within optometry, we can do intra-optometric referrals. And
Oh,
so I'm going to start telling patients they need to go to Medina, and they're going to say, "To your Dinah?" And I'm like, "Yeah, Medina." And I want you to go to complete eye care of Medina.
and you're gonna tell them it's funky and cold.
Yes. Well, not always cold. You guys, what's the weather right now?
Oh, it's actually beautiful. We've had a lovely 70-degree day today. So
That
it's
is so yeah. So whenever people say, "Oh, you're in the desert," yeah, it's 92 degrees today. No, no, thank you. Too soon. Not ready for it. Dr. Wesley, Gina, thank you so much for joining us on Collaborative Corner, the podcast. You're amazing, and just keep doing what you're doing because you're making all of us shine.
well,
Appreciate you.
likewise, Mark. Thank you for having me.
Everybody, we'll see you whenever I see you again. I don't know. We'll see if they bring me back. We'll see you in the next quarter. Take care.